All right, let's jump right into this explainer. Look, if you're a physiotherapist, you already know the deal. Treating vestibular migraine, or VM, requires a completely different playbook than your standard unilateral vestibular hypofunction. Today, we're laying down the absolute foundations of VM rehab, trigger management, and those crucial lifestyle pillars.
This explainer is based on the literature review, Vestibular Migraine, Rehabilitation Approaches, Diagnostic Criteria, Lifestyle Pillars, Cautious Habituation, published by Australian Dizziness Clinics. It's available for you over at australiandizinessclinics.com.
So here's our roadmap for today. We'll quickly cover the clinical vestibular dilemma, the VM trigger wheel, foundational lifestyle pillars, why aerobic exercise needs to take the lead, hormonal co-management, and finally, your key takeaways. Let's get to it.
Section 1. The clinical vestibular dilemma, and why standard VRT often just outright fails. Think about the painful reality so many of us face in the clinic. Most therapists open VM rehab with standard VOR exercises, right? High-frequency gaze stability, aggressive habituation to motion. But what happens? You immediately trigger a massive headache or photophobia flare. Why? Because the patient has impaired habituation. VM patients actually sensitize to repeated motion instead of desensitizing to it. And because of that, you lose the patient within the first 2 weeks. But the therapists who lead with an aerobic exercise base, they create steady gains. They actively raise the patient's trigger threshold, and they improve sleep all at the same time. Moving to Section 2, the VM trigger wheel and cumulative episode triggers. Now, to understand how to build up that threshold, we have to understand what actually crosses it. The fascinating thing here is that VM episodes are rarely ever just single-cause events. Let's think about the VM trigger wheel: sleep, hydration, dietary, hormonal, sensory load, and stress or weather changes. A huge clinical paradigm shift is realizing that no single trigger causes an episode on its own. It's an accumulated load. It's literally like a bucket filling up. A night of poor sleep, plus skipping a glass of water, plus a sudden drop in barometric pressure, they all stack up until they cross that individual's threshold, tipping them right into an episode.
Because of this cumulative effect, a patient-led symptom diary is actually your highest yield assessment tool early on. Just capturing 2 weeks of data on sleep, food, stress, and episode timing will identify the dominant triggers for about 70% of your VM patients. The big takeaway? This diary is way more useful than any objective vestibular test for figuring out what's actively driving the pathology and guiding your lifestyle prescriptions.
All right, Section 3, the 3 foundational lifestyle pillars: sleep, hydration, and diet.
Let's start with sleep. But listen, we aren't just giving out general sleep hygiene advice here. We're talking about strict sleep regularity, maintaining incredibly consistent bed and wake times, aiming for 7 to 8 hours a night. The literature identifies this as the single most evidence-supported lifestyle lever in vestibular migraine management. Getting your patient to anchor their wake time 7 days a week is absolutely non-negotiable.
Next up is hydration, and we need hard numbers here. The magic number is 30. That's 30 milliliters of water per kilogram of body weight per day. Hitting this specific, measurable metric significantly reduces episode frequency in a huge subset of VM patients. It's a simple target, and you can set it on day 1.
And for our third pillar, diet. Honestly, the biggest pitfall here is making abrupt changes. For instance, did you know abrupt caffeine cessation is a massive trigger itself? You want to maintain a steady caffeine intake, and if they need to cut back, taper it slowly over a fortnight. As for food, skip the blanket dietary restrictions. Rely entirely on that diary-guided elimination we talked about to spot specific offenders. You'll want to keep a close eye on common culprits like tyramine, MSG, nitrates, and alcohol, especially red wine.
Section 4. Aerobic exercise as the lead intervention.
This brings us to the biggest clinical paradigm shift for vestibular physios. How do we approach physical rehab when standard movement drills make them feel worse? Well, looking at the 4 pillars of comprehensive VM management: lifestyle, prevention, acute rescue, and rehab, aerobic exercise sits directly under the lifestyle pillar, acting as the ultimate bridge to rehab. In VM management, aerobic conditioning isn't just a nice little add-on to head and eye drills. It is the tip of the spear. It should lead almost every single program.
The specific protocol we're aiming for is exactly 30 minutes, 4 to 5 times a week, sustained over an 8 to 12-week period. Why? Because most motion-sensitive VM patients tolerate aerobic exercise way better than head and eye drills in those early weeks. Plus, a steady cardio routine hits 3 birds with 1 stone. It supports overall recovery, it actively raises that trigger threshold, and it drastically improves sleep regularity.
Now this is a massive clinical pearl from the literature. Aerobic exercise is the only level A non-pharmacological intervention in vestibular migraine for episode reduction. You absolutely must lead with it. Build their physiological tolerance first, and then, and only then, layer your VRT cautiously on top of that aerobic base 2 to 3 weeks later.
Section 5. Hormonal triggers and co-management.
So what happens when you do everything right? Even with perfect lifestyle tracking and aerobic adherence, conservative care has a ceiling. You have to know exactly when to flag a patient for vestibular physician co-management.
Treating VM is rarely a solo job. You need a highly collaborative care model. You, the physio, own the lifestyle pillars, the cautious VRT, and tracking the outcomes. The physician owns the diagnosis, prophylaxis, and hormonal review. Vestibular rehab works best when prophylaxis is optimized, meaning if a patient is still consistently flaring despite your conservative management, get them jointly reviewed with a physician before you try to just push through and escalate the rehab dose. The medication is the lever here, not the exercise.
So, what are the exact red flags for escalation? You'll want to flag the physician when episode frequency exceeds 4 per month despite lifestyle changes, when their dizziness handicap inventory remains over 50 at the 12-week mark, or if any new neurological features pop up. But pay close attention to this one. You must flag perimenopausal women for a gynecology and vestibular physician review right at session 1. Hormonal fluctuations in perimenopause are a dominant, complex trigger, and trust me, you cannot fix that with a treadmill and a sleep schedule.
And finally, Section 6, Takeaways and Next Steps.
We've covered a tremendous amount of ground, so let's distill it all into a core clinical workflow you can use tomorrow morning. 1. Lead with 30 minutes of aerobic exercise. It's your level A intervention. 2. Enforce those hard metrics, strict sleep regularity and that 30 milliliters per kilo hydration target. 3. Don't guess on diet. Use a 2-week diary to hunt down specific triggers. And 4. Never hesitate to co-manage, especially when hormonal triggers or a high symptom burden outpace your conservative care.
So once you've built this solid aerobic and lifestyle base, how do you actually introduce head and eye movements without sending your patient into an absolute tailspin? In part 3 of this explainer series, we're going to cover the precise mechanics of vestibular rehab in VMOB. We'll detail cautious dosing, strict habituation limits, and explain exactly why standard VRT volume flares your patients and makes them drop out in the first 2 weeks.
For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of the explainers in this series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. Until part 3, I want you to ask yourself, are you pushing your vestibular migraine patients too hard, too fast,